I've been asked to make a few words on behalf of the HDC Secretariat, and it's great to see old friends here on the call and colleagues. Great to see Alvin again. And I've mainly got three messages. One is a huge thank you to AeHIN for helping to host this webinar. You're going to hear a lot more from AeHIN, but also my colleagues Tashi and Pandula. But AeHIN is, as you know, a huge network and has been a big supporter of many global health initiatives with country impact, such as the Health Data Collaborative. Any collaborative is only as strong as its members and its partners. And I just want to acknowledge the strength and support within AeHIN, and anything that we can do to further that support from different quarters. We're very open to suggestions. The second thing I wanted to say, really, you'll hear during this webinar, and the objective of this webinar is to help you on the call better understand what the Health Data Collaborative does and what it could do for you. So we hope, beyond the presentation and what Tashi and Pandula are going to say, that you really ask some frank and sometimes difficult questions. So for example, sometimes like any global health initiative, many participants want to know, okay, so will this add to resources for me? How will this benefit me in my country and benefit my country? Ask those questions, and I'm hoping that there'll be a really good frank discussion on that and how the partnership within the Health Data Collaborative works as well. And I think the last thing I want to mention as well for this webinar is, like anything, the Health Data Collaborative is an informal collaborative. Myself, Pandula, Tashi, and another colleague, Mwenya, we play a role of secretariat, but it is your collaborative. So really, it's only as strong as what you want to make it and how you want it to work. So again, we value your suggestions on not only improvement, but what you want the Health Data Collaborative to do. You'll hear the three objectives of the HDC from Tashi and Pandula. What I think is clear for us as we work in WHO is the huge reporting burden faced by countries and the fragmented nature in which data is collected, synthesized, and analyzed, and how silos don't often speak to one another. And the Health Data Collaborative is one avenue or approach that can reduce the fragmentation and reduce reporting burden as well. So with those three key messages, I wanted to hand back to the AeHIN Secretariat and Pandula and Tashi, and thank you very much again to AeHIN for hosting this webinar, and looking forward to a good, frank discussion and hearing your suggestions as well. I didn't introduce myself at the start, but my name is Craig Burgess. I work in WHO headquarters. Part of my work is on data governance, and the other part is on partnership. So welcome to the webinar, and over to you, Tashi and Pandula. Thank you.
Thank you very much, Craig. Thank you, Craig, for setting the tone and for delivering very key, important messages, especially related to the HDC and its work. And as Shah mentioned, I'm Tashi Chozom, and I work in the Data Coordination, Governance and Partnerships Unit based in WHO headquarters. On behalf of the team, Craig, Pandula, and I are very excited to be here, and we're very thankful to AeHIN for giving us this opportunity to talk about the Health Data Collaborative, the HDC in short, and in particular, talk about how it can be leveraged to support countries' health information systems. I will begin the presentation by providing a brief introduction to the HDC, basically highlighting on its genesis and the objectives of the HDC, and hand over to Pandula, who will then take us through the mechanisms through which the HDC works and the principles that guide our engagement with the countries, and also, most importantly, touching upon the added value of the HDC. And first, let me talk a bit about what we are. Next slide, please. So the HDC was launched in March 2016 as a UHC 2030 initiative, following a 2015 high-level summit on measurement and accountability for results in health. And it was held jointly by the WHO, World Bank, and USAID. And it resulted in the endorsement of a roadmap for health measurement and accountability, and also a 5-point call to action. So the roadmap for health measurement and accountability, it identified a number of strategic actions, and this drove the initial concept of the Health Data Collaborative, which was around strengthening countries' data sources, generating global public goods, and also improving the coordination mechanisms around donor behavior. So as Craig mentioned earlier, it is an informal collaborative of over 1,000 members and over 300 partner organizations, and it is not a funding entity per se. So the HDC provides a platform for partners to leverage and align technical, financial, as well as political resources with country-owned strategies and plans across the data journey, starting from collection to data use, focusing on the SDG targets with special emphasis on communities left behind. It is currently hosted by WHO, and as Craig mentioned, our team supports the secretariat functions of the HDC. And moving forward, we're also very keen to explore how it can be co-hosted in partnership with other organizations as well. Next slide, please. HDC's work is centered around three key objectives to strengthen, with the ultimate aim to strengthen countries' health information systems. The first objective is to build country capacity so that countries are able to plan better, implement better, and monitor and review progress, and at the same time standardize processes for data collection, availability, analysis, and use. The second objective is to improve the efficiency and alignment, especially with regard to fragmented technical and financial investment in the global HIS space in particular. And the third objective is to increase the impact of global public health, global public goods and tools on country health data systems by encouraging sharing, knowledge brokering, learning, and country engagement. Next slide, please. So now on this slide, on this part of the presentation, just to highlight on who we are, we always say that data is important, but again, there's the subsequent question that data for what? So at this juncture for the HDC, it is to offer a coordinated approach to support the achievement of the SDGs, but with particular emphasis on communities that are left behind. This is why we closely work with the SDG 3 GAP Secretariat, which is the Global Action Plan for Healthy Lives and Wellbeing for All. And it is a set of commitments by 13 multilateral agencies to strengthen collaboration towards achieving the SDGs. Next slide, please. Thank you. Now to talk a bit about how the HDC is governed. Pandula, in the later segment of the presentation, we'll be talking about in detail, but just to say, just to touch on it a bit. So there are 7 constituencies in the HDC with diverse background, and this is where our strength lies, in the diversity of the group, and is based on the premise that no one partner does not have all the resources to address the HIS gaps, the data digital gaps in the countries. So through this mechanism, through this constituency-based framework, we have a diversity of viewpoints, diverse technical and financial resources, expertise, based in different geographical regions, different context, and also gender as well. So the 7 constituencies, as you can see on the screen, we have countries, which of course is the essence of our work and is the center, at the center of all our efforts. We have the private sector, we have global health initiatives like Gavi, Global Fund, etc. We have philanthropic organizations, we have the civil society organization as well, for example, PATH and Save the Children. We have academia as well, and research networks, and AeHIN is a part of this constituency and a very close partner that we value very much. And similarly, we have Johns Hopkins, we have the University of Oslo, and the 7th constituency is the multilateral and intergovernmental organizations like UNICEF, UNFPA, UNAIDS, OECD, etc., World Bank, etc. So a majority of our partners belong to the research and academia constituencies, and we have to admit that countries are the least represented in terms of numbers, and we're really hoping to engage more with countries and increase the representation from colleagues from the countries in the HDC, and we rely on webinars like this to talk about the HDC, to advocate for the HDC, and so that our partners and members, countries, and from other constituencies are aware about it. And it's an open collaborative, and it's where everybody is welcome to join. Next slide, please. And we have 7 technical working groups, which is again on the screen: the CRBS working group, the Logistic Management Information Systems working group. We also have a working group on GIS. We have a working group on data, digital health governance, routine health information systems, community data, and digital health and interoperability as well. And I see it as we're sitting on a huge gold mine of different diverse experience, expertise, and resources that can be potentially leveraged through these working groups for country needs, country priorities to address data and digital gaps in the countries. So thank you very much. And with this, I would like to hand over to Pandula, who will go ahead with the next segment of the presentation. Thank you so much.
Thanks very much, Tashi, for that excellent foundation and giving us the background of what we are and who we are. So I'll build up on where Tashi left to give all of us some insights into how we work and the process of doing so. How does the country engagement takes place? And then we can move into the vital discussion where we can share ideas, use suggestions, as well as clarify areas that may be unclear. So when it comes to how we work, I take a step back and talk a little about why we do what we do, so to say. If we look at our own context in terms of health data systems, we see a lot of fragmentations in relation to these data systems due to various reasons. Reasons can be in the form of technical support that may have received. It may be based on funding. It may be based on changing interests or priorities within a country context, or various other reasons. What the fragmentation does, however, as you all are aware, is to reduce the efficiency and reduce the coordinated action and response. And this ultimately prevents us from achieving the full potential that we are capable of using health data. And this is what HDC strives to avoid and minimize in particular LMIC context. The way of doing that is by offering a more efficient approach to partner engagement, financing, and reporting of health data by countries. I will explain these in a little bit more detail later on. And the core to this particular effort is the HDC's governance structure and the theory of change that it used. I'll briefly touch upon these. Tashi has already touched upon these to a certain extent, but I'll touch upon these in order to elaborate how the HDC functions, so you have a better understanding of the modalities of work. When it comes to governance of the HDC, as Tashi explained, we have the technical working groups. We have the constituencies represented by the civil society, the country's donors, multilaterals, global health initiatives, and so on. And we have the working groups for different areas such as CRBS, community data, the governance, interoperability, GIS, RHIS, or routine health information systems, and logistics and management. So these are the we can we can refer to these working groups as the cogwheels in our operations within the HDC, because this is where the representations from different members of the HDC work together in order to solve problems related to country priorities or related to global public goods or anything related to health information systems and data systems. In addition, we also have within the governance structure a stakeholder representative group, which again is represented by members of the technical working groups from each of the 7 technical working groups, as well as members from the global partners group, which include many of the other members. And as the Secretariat, as Tashi explained, we are accountable for the stakeholder representative group and facilitate and coordinate the work related to the technical working groups and various other gatherings that are facilitated or meetings facilitated through the HDC. So this is basically the core or the engine, to say, of the HDC, how it operationalizes the different work that I will be talking about a little bit later. The approach, this is just to illustrate that the HDC's approach will always center around national health plans or national health priorities. And this is always the key for the HDC's engagement in a country. I will explain it a little bit more detail in country engagement. And ultimately, it will strive to set up a common technical and financial investment framework for M&E and single country-led health information systems. Now, many of you would think, yes, it's that easier said than done. And definitely it's a difficult task. And however, the mechanisms are such that the different needs of a national health plan or the priorities set up by the Ministries of Health or any entity responsible for the health information systems or data systems can be fulfilled through a collaborative approach. And this has been tested in different contexts. To certain extents, in some contexts, it works. In some contexts, there may be various reasons for it not optimally work. But then there may be different approaches in different contexts, because we realize that each of the countries have its own mechanisms of work, engagement, coordination, and even priorities. And therefore, the engagement may be different from one context to the other. Now, there are several principles that governs the HDC's engagement, and this may be important when seeking to when HDC approaches a country or when countries initiates their response. First of all, the engagement with a country will not be by selection. So to say that HDC will not select a particular country and focus on that particular country by its own self. It will be by invitation, meaning that countries will initiate the process by expression of interest, most likely through the country office of the WHO or through similar mechanisms. And this basically creates a strong country-led stewardship towards health information needs that are put forward for to be supported through HDC's mechanisms. So it's an important thing to remember. Although the countries will initiate this process, often what happens is that, first of all, the countries need to know what HDC is. And this happens, as Tashi explained, through webinars such as this, or it may be through bilateral engagements taking place maybe on the sidelines of events such as the World Health Assembly or any other such events, or even advocated through by the regional officers of the WHO and other partners aware of the potential benefit that the countries may gain by engaging with the HDC's process. The HDC's involvement or engagement may also be opportunistic. The reason for that is the mechanisms of the HDC to work. There also needs to be potential. I will discuss it a little bit more in next slide. But the alignment, collaboration, and these opportunities doesn't always arise. But when it's present, countries needs to latch on to these opportunities to collectively fulfill their health information needs. And therefore, this is why the HDC is often on the lookout and supports countries with the opportunities that arise. And that's one of the means of engagement as we work with countries, and aligned at all levels. And this is important because HDC is not looking at a top-down approach, and HDC is not necessarily working alone because its structure is such that HDC always works at 3 levels, so to say, at country level, the region level, as well as at the global level, at the HQ level. So as we work at these multiple levels, there is better chance that the resources are better aligned, partnerships are built, collaborations are built, and resources are effectively mobilized. So these are 3 principles through which the country engagement may take place with HDC. And when we talk about engagement and where the potential for engagement, can list several such instances. For example, when there is potential for collective action and aligned investment in data, that's an opportunity for the countries to benefit from the HDC's approach. This may take place, for example, the country may have a digital health blueprint, for example, but no single partner or a donor agency may be able to fulfill all the requirements of that particular blueprint. And in order to achieve the priorities or fulfill the priorities for that particular country, there needs a mechanism to coordinate between multiple partners who will be able to bring in their own resources to fulfill different components of that action plan and work together in harmony to achieve a final collective objective. And this is an opportunity where HDC would be able to facilitate. Another instance would be where in potential for technical cooperation and coherence. This may be in instances where countries would have multiple health information systems, multiple data systems, which do not necessarily communicate with each other. The interoperability is a problem. And in such instances, it's necessary for different partner organizations, entities to come together and collectively approach this problem for the betterment of the country information systems. So this is again a potential area where engagement may be facilitated. Political interest in data is another aspect that the HDC and the partners would be able to support countries with or engage with countries. The reason being that the mechanisms or the high-level engagement of different partner organizations, including the WHO, and the trust that has been built around the WHO and UN agencies can be leveraged to build the political will towards better health data. And that's an important advocacy role that the HDC mechanism can facilitate in some of the countries. And also, HDC working groups are involved in various activities related to health information systems and data systems. And these may be in the form of developing global public goods, or various other tools that may be applied in different country contexts. And taking these work at country level is something that creates potential for engagement for the HDC and its partners. So there may be several other also instances where there's potential is created for engagement, and you can look at your own contexts and see where this where the HDC may be able to facilitate a particular activity when you look at some of these instances or scenarios for engagement. Now, I told you about the theory of change that the HDC adopts as it engages with countries. And as you know, theory of change lays down a robust mechanisms through which a change may be achieved. So what the HDC adopts here is that if the HDC make use of resources related to advocacy, financial, technical, through its partners, and implement strategies such as capacity building, coordination and alignment, contextualization of global public goods, it will result in sustained institutional capacity to collect, store, analyze, regularly report, and use data at all levels. It will facilitate result in greater alignment with national plans and priorities, and it will also result in increased capacity to assess need and use of global public goods and to introduce new technologies while stimulating innovations. This is the theory of change, which thereafter will give rise to the outcomes of increased autonomy and reduced reliance on external technical resources, less fragmented and more efficient approaches to data collection, storage, analysis, and use, also decreasing reporting burden, and increased innovative approaches to local contexts. So why I basically went through the theory of change is that this is a robust, clear mechanism which all those engaged could understand. And within this, we have different tools that enables us to engage in a dialogue with the countries. For example, we use the SCORE for health data, the SCORE health data technical package as a dialogue builder with countries, because it allows us to identify critical gaps and inequalities in terms of health information systems and health data in a particular context. So a methodical approach always helps the partners, as well as the countries, because all are clear and aware about the approach that HDC may facilitate. Let me talk very briefly about the impact and the added value, because this is a question that always arises as we engage with partners. What's the added value to us? And I think Craig also mentioned this. These are important questions to address, but I will address this up front. There are several examples of impact I will bring in here. One is, for example, the harmonized health facility assessment. And this work facilitated by the HDC has brought together multiple stakeholders through its mechanisms to come up with a single harmonized assessment for health facilities, making use of multiple surveys that would have been otherwise used in the countries, burdening its health system in order to gather the same lot of data. So this has now been developed and implemented in multiple countries and has greatly reduced the burden of using multiple instruments. So this basically is an example where collective action leads to effective utilization or creation of tools to gather data and to report, reducing the burden on countries. The country missions is another approach the HDC has adopted. This is when there is a need and it's led by the partner organizations. And these will ultimately lead to strategic guidance for ministries of health or the state agencies, native health information systems and data systems. There are examples of alignment of country needs with partner resources. when a country comes up with a list of priorities or health information system priorities, the HDC becomes a spokesperson for the country, for the region, with the stakeholders and partners, and bring them together through already established mechanisms. It may be at the HDC level through working groups or stakeholder SRG, or it may be at the country level where there may be a coordination mechanism set up for different partners. Capacity development is a recurring theme in many of our efforts. So the resources being utilized through partner institutions, as well as technical supports being provided for capacity building initiatives in some of the countries. And the reducing the burden of data collection and improved quality in example, countries like Malawi, and the initiatives towards co-investments from partners. The example given here is Tanzania. And of course, one of the biggest value adds of HDC is the creation of this platform or opportunities for partnerships through various mechanisms. And that is immensely valued by many of the partners, as well as representatives of various institutions in countries, because that dialogue otherwise will never happen. And once the dialogue happens and commitments are created, this basically enhances or fast tracks the work that the countries strive to do in terms of health information systems and data systems. Again, these are easier said than done, because HDC is not a funding organization, it's not a funding mechanism, but still it's a mechanism where we can be a voice for the countries to bring in the partners or link up with the partners, create opportunities for partnerships. And that's what the HDC is striving to. And of course, documentation and alignment case studies. These are learning resources for our work. In some instances, it may be successes, it may be failures. Both contribute to learning, and with learning has immensely helped both the HDC as well as the partners in engaging with countries. Briefly, talking about further value adds in terms of different areas. For example, increase efficiency for support, context specificity, reduce reporting burden, greater power to the civil society, health security for all, leaving no one behind, especially because of the focus on communities that are left behind and inequalities that are created, strengthening and data and digital, because sometimes we see a less harmonized pathways in terms of health data as well as digitalization processes, but we strive to align these two in terms of regenerating a better outcome. And of course, expertise and quality focus. And Tashi mentioned about the involvement of academia with the HDC, and this also enables us to greatly use quality technical insights, evidence-based insights when it comes to fulfilling some supporting countries with their needs. Last but not least, I will briefly explain the country engagement pathway in a very simplified diagram. Of course, it may not be necessarily the same for all countries, and sometimes these steps may overlap. But when a country engages with HDC, as I said earlier, it will be country initiated. A country request for support may be made through the WHO's country office and communicated through the regional offices to the HDC and its other partners. And here the opportunities for alignment and collaboration will be identified, and that's what basically enables countries or triggers country requests for support through the HDC or enrollment with the HDC. And once such a request is received, It will be deliberated through the working groups and through similar mechanisms. And in view of identifying potential resources, not necessarily only financial support, but particularly in most instances, it's technical support, roles in terms of advocacy, and of course, any other resources that will help fulfill these country priorities in terms of information systems and health data. The next step obviously would be mobilization of resources, and this may require deliberations with at country level, the regional level, as well as at the HQ level, at a global level, and identifying and integrating investment, financial investment plans of different agencies and partners with the country needs or aligned with country needs is something that HDC strives to do through its mechanisms. Lastly, of course, the country engagement will take place through a coordinated mechanism. The HDC will not strive to set up new coordination mechanisms and burden the countries, but always strive to use existing mechanisms for partner engagement and facilitate sustained engagement of these partners with a focus on the country priorities. So this is basically how the HDC work with countries. And I hope I was able to, along with Tashi, give an overview of what HDC is, how it works, what it's basically made of, and also the process of country engagement. I think we are ready for a Q&A, the Q&A. And we are happy to answer any questions that you may have, clarifications, and also suggestions, because some of you might have already engaged with the HDC's work. You may have recognized areas that HDC can improve. Those suggestions are also very welcome, because we always strive to improve the HDC's ability, and because it's always based on the country needs and adopting best means of fulfilling these needs. Over to you, Shah.
Yes, thank you, Dr. Pandula and Miss Tashi. Actually, we already have a number of questions here, so maybe we can start with the chat box.
Okay.
We have a question from Dr. Bunchai asking, how is the HDC and the Division of Digital Health and Innovation at the WHO HQ related?
I'll try to take that question, Pandula, if I may.
Sure.
So the Division of Digital Health in WHO is a separate division, but we work very closely because a lot of our works overlap, as you can clearly tell. And also, colleagues from the Digital Health and Innovation Division are members of the HDC, and we rely on their expertise. We rely on their advice as to, especially with regard to digital health, interoperability working group, as well as other areas. So this is how we collaborate in a nutshell.
Yes, thank you, Ms. Tashi. Our next question is from Dr. Karma Tenzin. How is the HDC different from other similar collaboratives?
Thanks. It's a very good question. Well, Tashi, please add to what I'm saying, and maybe Craig, if you're also there, you can also add to this. Well, HDC's probably main strength is its members in terms of 7 constituencies that it has. And these diverse viewpoints come together through a very well-structured mechanisms, through working groups, through stakeholder governance mechanisms, and so on. So I think this is one strength or one aspect where it differentiates itself. And the second, I would say, is that we always strive, we adhere to the principles as I described earlier, where the engagement is country initiated, and so that it's always focused on the country priorities and not necessarily on partner priorities or any other third party interests. So that's again another difference as I see. Of course, we see there may be other collaboratives also working in similar nature. But I think these are two differences that I can, highlight. Maybe Tashi or Craig,
Yeah,
you can also.
Thank you,
point out.
Pandula. Thank you for that. I'll just add to what you've already said. Yes, so there are a number of organizations with similar mandates to the HDC at the global and also at the regional level, each with different strengths. Some examples would include the Transform Health, which is a global coalition, Digital Square, and also the WHO Hub for Pandemic, Epidemic, and Epidemic Intelligence. But as far as I know, and we were told before that there is no collaborative that convenes such a broad range of stakeholders as Pandula rightly highlighted. And our diversity is our biggest strength. And we recognize the strengths of these organizations. And most of them, for instance, the ones that I mentioned, Transform Health, Digital Square, etc., are all part of the HDC. And we try to work together, work very closely with them. And also in comparison to these initiatives, one of the main differences is also the mandate of the HDC is broad. For example, Transform Health and Digital Square, they focus more on digital health. WHO Hub for the Pandemic and Epidemic Intelligence focus more on disease surveillance. So the technical focus of the HDC is very broad and it is very inclusive, as we've highlighted through the 7 technical working groups. And also members in the past have said that the HDC CRVS working group is the only forum convening stakeholders working on CRVS globally. Please correct us if you're wrong. Thank you.
Yes, thank you, Dr. Pandula and Ms. Tashi. Our next question is from Dr. Alvin, but I think this was already shown on the presentation about the engagement of countries and HDC partners. But he also asked, does it require some form of letter or expression of interest? And can HDC share an example of how the letter may look like?
Well, as far as I'm aware, there's no template as such, but this will be country specific sometimes. Sometimes it may take the form of a simple letter expressing interest to engage with the HDC. Sometimes it may take the form of a concept note that may have already been developed in terms of country health priorities. And so it might differ from one country to the other. But again, another question that I saw was there is that what are the qualities for a country that may be invited to join HDC? The invitation is not by the HDC, but invitation is emerging from the countries, and the countries initiated the dialogue, wanting the HDC process to be utilized in that context. And that's where we want to sensitize the countries about HDC. What is the opportunity presented, the value add presented through the HDC, so that the countries can decide for themselves whether it adds value to the HIS priorities or health data priorities in fulfilling those priorities. So Tashi, do you want to add to that?
I just want to say that there is no requirement whatsoever. The HDC is open to everybody, anywhere, any country or any individual from any organization who works in health in data and digital, in the data and digital space, or who's interested in the data and digital space. You're all welcome to join. I have shared the link of the HDC website, where there's a button at the bottom of the web page, become a member. So you can click on that, and also alternatively, you can also write to us at hdcsecretariat@who.int. I think I've also in one of the questions, I've replied to a question in the chat with the email address of the HDC as well.
I can also share that recently Sri Lanka expressed its interest in terms of joining HDC, and this was triggered by the recently developed digital health blueprint that the Ministry of Health now wants to operationalize and to seek support to bring partners together in terms of fulfilling the priorities that are defined through that. So this is one way of engagement with the HDC, and probably one of the forms of doing so. I can move on to another question.
Yes, Doctor. We have a question from Dr. Daniel Rosen. Can you please share examples of successful engagements?
So I guess one of the slides, if I can share, just share again. Hope you can see. So what's being highlighted here are perhaps some of the successful engagements in different forms. I wouldn't say in some instances they are complete or have yet to mature to its full potential, but these are some of the things that could be discussed. The HDC's engagement, I would have to say, is more significant in the African context than in the Asian context, but it's probably the reason being that initial pathfinder countries largely being in the African context. And now only the HDC is looking at scaling up, expanding into other regions, including Sierra, Wipro, Emro, and other regions. So it may be one of the reasons probably for more of the African region countries being part of HDC, maybe due to that. So this is some of the highlights. We can share the slides with the participants. And I think if you visit the website also, you could see some of the examples reported there, including alignment case studies of different countries, also published in the website mentioned in the bottom corner of this slide.
Yes, thank you for sharing that, Dr. Pandula. We have a question from Dr. Shedmore Saline. Can you quote some example relating to your coordination or support for CRVS?
Tashi, you have any?
Yes, I'll take a stab at answering that question. We have the CRVS working group, and it is chaired by WHO, UNICEF, and also the London School. And the group is made up of diverse individuals from across different constituencies, bringing in different strengths, expertise, resources. And just to quote an example, one of the most recent engagement or initiative in this space was the mission that the HDC undertook to Nepal. And CRVS was one of the focus of the mission, including GIS as well. So these are some of the ways in which the HDC engages with the countries, and the mission. After the mission, a strategic brief was developed, and so it was a joint mission, WHO, UNICEF, and UNFPA, and a strategic brief was drafted with specific recommendations that was submitted to the government of Nepal for their consideration. And of course, the work doesn't stop here, and the HDC will continue to advocate for these the implementation of these strategic priorities, and see how we can continue to advocate for Nepal to strengthen their CRVS. Thank you. I hope I answered your question.
Yes, thank you, Ms. Tashi and Dr. Pandula. Our next question is from Dr. Sonam Yangchen. Since HDC is not really a funding agency, but something like a coordinating mechanism, how do you make impact at a country level? And what are the modality of collaboration at the country level to reduce the burden of multiple reporting systems or fragmented data systems?
Thanks, Shah. Thanks, Onam, for that question. As I mentioned in my presentation, when HDC engages with a country, we look for existing mechanisms of collaboration and coordination within the country. And when there is an existing mechanism where the ministries of health or state agencies engages with the partners in terms of health information systems and health data, or even digital health for that matter, we make use of the same coordination mechanisms to engage with the partners at country level. And this is following the deliberations at working groups where the same partners may be engaged at a global level as well as at a regional level. So we basically become a voice for the countries, for that matter, at global level and the regional level, and try to make use of existing coordination mechanisms in the countries to facilitate and engage partners in a more effective manner using the various tools that may be used. And when there is no coordination mechanism as such in some of the countries, a local forum of HDC may be established, and this is contributed to by not only the development partners but also by the civil society, the private sector, similar to structure at the HDC globally. But we don't probably call it the HDC local forum, but there will be something that is led by the ministries of health or the state agency, whoever leads the health information system and health data efforts. So yes, there will be a local coordination mechanism, but it may not be anything new, but it may be the same mechanisms that we probably be using.
Yes, thank you, Dr. Pandula. We also have some questions in the Q&A box. So one is from Dr. Indira Sundiram. How are you supporting and advising countries on their digital health tools between programs, for example, TB and HIV, to utilize same interfaces, tools, and reporting systems?
Well, I guess this is, the HDC's engagement is always country-led. And when I say country-led, it's based on the priorities identified by the countries. And when countries strive to and as you probably have seen in our approach, central to, what the HDC strive is a common health information system where the data collection, storage, reporting may be done in a harmonized way. So I think it depends on the country context, and how we support will be to bring in all the relevant stakeholders or partners related to that particular country or the context, and facilitate the dialogue in order to see how best that the interoperability may be facilitated, or how best the reporting burden may be reduced. And this is always a form of advocacy that HDC will undertake along with its partners, the WHO country office, as well as all other stakeholders involved. And it's through dialogue that we will be able to achieve this. We don't advocate any particular tool or solution apart from the global digital public goods, if that is applicable in that particular context. But it will always be based on the country request and recognized priorities they are in. Tashi, I don't know whether you want to add anything to that.
Not on this, but I also recognize some questions in the Q&A box. Sure, I don't know if you have seen those.
Yes, we also have a question from Dr. Wang Di. from Bhutan. The first question is, does the HDC assess the data priorities of the countries, and how do you do it?
I'll try to answer that, Pandula, if I may. Thank you for the question. It's a great question. There are certainly different ways through which we try to understand the HIS priorities in the countries. One straightforward answer is we normally engage in dialogue with countries and directly ask them what their main priorities are, and also at the same time relying on the regional and the country offices, not only in WHO, but also other partners as well. We also conduct desk reviews, mainly reviewing the data and the digital health related strategies and plans of the countries, because we believe in one plan, one M&E framework for all the partners. And we also try to review which partners are involved and working in the countries in several, in different HIS areas. So our main principle is not to reinvent the wheel. We always try to look at what is already in place. We are also guided by WHO SCORE assessment. SCORE is a technical package of essential interventions, recommended actions, tools, and resources that aim to support countries to address the gaps in their HIS. The latest SCORE assessment was carried out in 2020, if I'm not wrong, covering three years, and it showcases different HIS gaps in around 130 countries. So we use that report also, and because to tell us where the gaps in the countries are in terms of data availability, quality, also synthesis and analysis, and also access and use as well. And we try to use it as a conversation starter with countries and partners alike. So the next SCORE is planned sometime in 2024, 2025, and I think it will be when it's done, and it will be good because we can actually monitor how countries are doing in the 5 interventions, SCORE interventions. Thank you.
Yes, thank you, Ms. Pandula. There's a next question from Dr. Wang Di. What are the challenges confronted by the HDC? How can a country from low resource setting improve efficiency in health management information system, given its sizable investment or budget that goes along data collection, which otherwise could be diverted for health services?
Pandula, may I go ahead? Try to
Yeah,
answer,
sure, sure, please.
Okay. So HDC, it's such a huge collaborative and informal collaborative, and it's not without challenges like many other collaboratives. Firstly, at the operational level, the management of such a huge collaborative of over 1,000 members, of over 300 partners, it's very challenging. Just as simple as organizing a meeting, because we have more than 1,000 members. We have, to communicate frequently and organize meetings. Members may be based in the Philippines. Members may be based in the US with a 12-hour time difference. So things like that are very challenging, and also in light of limited staff. But mostly, because the HDC is not a funding entity, and the moment we engage with countries, there are expectations, which is normal, which is natural. So these are some of the challenges that we try to navigate, and we always, in light of these challenges, we always try to advocate what is the added value of the HDC, and Pandula has very well demonstrated our added value. We have partners on the one hand, we have the countries with the HIS needs and HIS priorities on the other hand. What we do is we try to shed light on those priorities and try to bring in partners, the different resources, technical, financial, political resources that they may have to address these priorities. So these are some of the challenges, and how we try to navigate these challenges to better support countries and other partners as well, to avoid to break silos, to break fragmented approaches to HIS globally, regionally, and at the national level as well. Thank you. If you have anything to add, Pandula.
Well, just to add, it's always challenged the partnerships, collaboration, alignment. I mean, doesn't take place overnight, and it takes time, a lot of patience sometimes, and a lot of deliberations between partners, countries, and the difference between countries, the way they work, the contextual differences, priority differences, socio-cultural factors, all those and expectations, all those contribute to the challenge faced by the HDC. But I think our tasks is always guided by both the HDC's principles as well as the WHO's core values, and also the trust that is placed on the organizations such as WHO and the other partners, multilateral agencies, UN agencies involved with the HDC. So we are always guided by those values and methodologies in terms of engaging. So we have we do feel the challenges often, but we sustain and try to deliberate to the benefits of the countries as much as possible through those challenges.
Thank you, Dr. Pandula and Ms. Tashi. We also have a question from Dr. Gumindu. Is there any plans by HDC to play as the middle person in sharing digital health products or concepts between regional countries?
Well, to be specific, the HDC, one of the pillars of its engagement is contextualization of global digital goods. So in that sense, the HDC may play a role in introducing these tools to countries, technical packages to countries, and also working with them in terms of operationalizing those tools. So in that sense, yes, but apart from that, it may be on the needs basis as we move forward, but the focus is largely on the global public goods and its implementation.
Thank you, Dr. Pandula. Maybe just for the last question, Dr. Faraz is asking, how can HDC collaborate with private organizations?
So the private organizations are very welcome to join the HDC. You will see that if you visit the HDC website, HDC healthdatacollaborative.org. If you visit that website, you will see at the bottom of the page, you have a link to join the HDC. And through that, then you can be part of different deliberations taking place. And you can always directly write to the HDC expressing your willingness to contribute. And the technical working groups, the contributions to these by individuals, by members, is purely voluntary. And that engagement is an expression of goodwill by these partner agencies and the commitment for this engagement. And that's what drives HDC and its efforts all throughout.
Yes, thank you very much, Dr. Pandula and Ms. Tashi. So to close our webinar, I would like to call on our chair, Dr. Bunchay Kichanayoti, to formally close the session.
Thank you, Dr. Pandula. Long time no see. We have met in Colombo several years back. And Tashi, and thank you, both of you, giving our webinar and give us many information about HDC, and we hope our community, the AeHIN and the HDC and another developing partner and also stakeholder can work together to enrich the health information and digital health in our region and globally. Thank you very much. And thank you everyone for attending this webinar.
Thank you very much. Thank you, AeHIN. Thank you everyone for taking part.
Thank
See you
you.
everyone. Bye-bye.
Bye.